Hello, everyone, and welcome to the 13th annual Clinical Diagnostics and Research virtual event organized by LabRoots. My name is Raj Pandya, and I'm an assistant professor of pathology at the University of Utah, and also a medical director of clinical chemistry and toxicology at ARUP Laboratories in Salt Lake City, Utah. So today we are going to talk about tumor markers as cancer screening and surveillance tools. So let's jump right into it. Disclosures, I have nothing to disclose. And there are three learning objectives of this talk. The first one is to describe the types and characteristics of tumor markers. Second is to discuss considerations for clinical laboratories that are offering tumor marker testing. And the third one is to explain the utility of CA-125 in ovarian cancer management. So before we dive into the tumor markers aspect, let's take a step back and ask the question, what is cancer? So cancer is a heterogeneous group of diseases that are related to each other, wherein cells in our bodies proliferate uncontrollably. And these cells that proliferate uncontrollably also invade surrounding and distant tissues as well. So you can see on your top right that there is a tumor that is proliferating and it is invading the healthy tissue below. And these malignant cells that are now invading the healthy tissue can also gain access to distant sites through blood vessels. And that's how distant metastases occur. As far as the description of cancer is concerned, the oldest description can be found in Egyptian literature around 3000 BC. And more recently, archaeologists in South Africa have found 1.7 million years old fossil of osteosarcoma, which is considered to be the oldest evidence of human cancer. As far as statistics are concerned, in the United States, in the year 2022, 1.9 million new cases of cancer are expected, and men would contribute around 1 million of those cases, and women would have a little over 900,000 cases of cancer. And unfortunately, just a little over 600,000 individuals are likely to die from cancer. So it's a pretty serious disease and financial burden. Now, what are tumor markers? So tumor markers are substances that are produced by a tumor or by the host in response to a tumor. And these are measured either qualitatively or quantitatively to identify the likely presence of a cancer. And interestingly, the first tumor marker was identified and put into clinical practice in 1847. And this is referred to as Benz-Jones protein, which we now know are urine light-free chains. On your right-hand side, you can see a timeline of tumor marker development as well as evolution of different assays that has occurred over a period of time. So as you can appreciate from this depiction, that pre-1970s, the tumor markers that were being used were Benz-Jones protein, lactate dehydrogenase, pap smear, HCG, carcinoembryonic antigen, etc. And the methods that were used were enzymatic methods or immunochemical methods. Between 1970s and 80s, new biomarkers, particularly in reproductive cancers field, emerged. And those are prostate-specific antigen, CA-125, which is for ovarian cancer, as well as estrogen receptor and progesterone receptors. And these were detected using radioimmunoassays or immunohistochemistry. Immunohistochemistry is still used in the clinical setting. In the decade that followed, which is the 80s to 90s, newer markers emerged, such as CA15-3, CA19-9, and HER2. And at this point, assays for measuring these biomarkers also underwent evolution and update. So these assays at this point were automated immunoassays. And in the decade of 2010, and from that point on, several more sophisticated assays were developed, as well as data analysis tools accompanying those assays, which led to development of certain biomarkers that are EGFR, BRAF, KRAS, etc. So what molecules can act as tumor markers? So there is a large variety, and there is a long list, as you can see here. So some of the molecules can be really, really simple, such as biogenic amine neurotransmitters, such as catecholamines, which serve as tumor markers for pheochromocytoma, which are adrenal gland tumors. Some tumor markers are hormones, such as calcitonin. Others are enzymes, such as lactate dehydrogenase. Some tumor markers are large mucin glycoproteins, such as CA125. And also, some tumor markers, as shown on the slide, are oncofetal antigens, such as HCG or alpha-fetoprotein. So the interesting thing about oncofetal antigens is that these proteins are normally produced during pregnancy by either placenta or by fetal tissues. And after the birth of the baby, the expression of this antigen is turned off unless there is a tumor development. So that's why these are called oncofetal antigens. And the last one on the list is antibody components, such as Benz-Jones protein, as we described earlier. So what are some characteristics of an ideal tumor marker? So there are 6 characteristics. The first one on the list is highly specific. So the expectation is that these tumor markers would be highly specific and only present in a specific cancer and absent in healthy state and in other malignancies. The second characteristic would be proportionality. So concentrations of the tumor markers would be proportional to tumor burden. And this would mean that if a tumor is resected, then pre-treatment or pre-surgery concentrations would be higher, and post-treatment or post-surgery concentrations of that tumor marker would be lower. Another ideal characteristic is short half-life, which means that levels of tumor markers should reflect current state. The fourth desirable characteristic is matrix. So these biomarkers should be easy to test in common matrices, which are tested in clinical laboratories, such as serum, urine, or biopsy tissue. The fifth characteristic is availability of convenient, reproducible, and inexpensive, and potentially automated assays. And the last but most important characteristic is clinical impact. So there should be a measurable impact on the clinical care of the patient if this biomarker is put into clinical practice. So now shown here is a depiction of sensitivity and specificity for tumor markers. And as you can see on your top left, that it depicts perfect test and its frequency distribution. As you can appreciate from this depiction, that the non-cancerous distribution is very different from cancerous distribution, and you can establish a very clear cutoff. At the bottom of that depiction is a questionable test where the two frequency distributions, no cancer and cancer, overlap significantly that you can't really draw a cutoff to differentiate between cancerous versus non-cancerous specimen. And on the right-hand side, you can see what is really found in practice. So these frequency distributions, no cancer versus cancer, overlap with each other. And it would be a compromise of the sensitivity and specificity to come to a cutoff that is acceptable to the laboratorian. So how are tumor markers used in cancer management? So there are 5 different ways that tumor markers can be used in cancer management. The first one is screening. So when we talk about screening, we mean identifying subclinical disease in asymptomatic patients. So this would be population screening for certain cancers. And a good example of that is fecal occult blood. And the context here is in the colorectal cancer. The second utility is diagnostic aids. So diagnostic aids would be, the keyword here is aid. And tumor markers can serve as an aid in diagnosis of cancer, particularly in symptomatic patients. And a good example here is serum AFP in the context of hepatocellular carcinoma. The third utility is prognostication. So prognostication refers to using tumor markers to estimate survival outcomes. And a good example here is serum lactate dehydrogenase in the context of germ cell tumors. Another utility of tumor markers is predicting therapeutic response. So again, a good example here is tissue expression of estrogen or progesterone receptors in breast cancer biopsy specimens. So if those specimens are found to have estrogen or progesterone receptors, then that would guide hormonal therapy for that patient in the context of breast cancer. And lastly, and most commonly, tumor markers are used in post-treatment monitoring. So there are 2 ways post-treatment monitoring might happen. The first way is that before treatment, a specimen might be collected and level of tumor marker might be estimated. And immediately after treatment, the level of tumor marker might be estimated to gain a sense of the effectiveness of the therapy. But in addition to that, more longitudinal measurement of tumor markers can also happen to monitor for cancer recurrence before symptoms arise. And a good example of that is serum CA-125 in the context of ovarian cancer. So there are several guidelines out there by different organizations that recommend specific tumor markers in specific circumstances. But here is an example of National Academy of Clinical Biochemistry recommendations for tumor markers. And this is a large table, but we'll go through a couple of examples. So the first one is alpha fetoprotein at the very top, and the relevant cancer type is germ cell or testicular tumor. As you can see that it is recommended by NACB in the diagnosis or case finding, prognosis, detecting recurrence, and monitoring therapy for those 2 types of cancers, so germ cell or testicular tumors. However, the same biomarker or same tumor marker can also be used for screening or early detection of hepatocellular carcinoma. And I also wanted to draw your attention to the last tumor marker on the list, which is thyroglobulin in the context of thyroid cancer, more specifically follicular or papillary thyroid cancer. And as you can appreciate from this table, there are only 2 check marks, and those 2 are for detecting recurrence and monitoring therapy, which means that thyroglobulin is not recommended for screening, for diagnosis, or for prognostication of thyroid cancer. So as laboratorians, we are very much interested in what assays are used to detect and quantitate these tumor markers. So here is a list of assays that are frequently used, and these assays have evolved over time. So back in the day, radioimmunoassays and immunoradiometric assays that utilize radioactivity were being used, but due to concerns around safety of the workers, those got replaced by immunoenzymatic assays, and subsequently more sensitive and automatable assays such as immunochemiluminescent assays or immunofluorescent assays were developed. And most of the serum or plasma tumor markers are now tested on automated assays. The last one on the list is immunohistochemistry. This particular kind of assay is used for tissue tumor markers such as estrogen receptor or progesterone receptors in the context of breast cancer. So now, what are some important laboratory considerations? There are several considerations that apply to quantitating tumor markers, and those are similar to all the other testing that goes on in laboratories, but some are special. So one of them is pre-analytical variables. So tumor markers are usually not known to undergo diurnal variation, and so time of the day when a specimen is collected is not really that important. However, what's really important is collecting a pre-treatment specimen, because that specimen can provide very useful information further down the road after the treatment is complete, and also to put things into context for longitudinal monitoring. Another important pre-analytical consideration is collection well in advance of procedures, such as colonoscopy or digital rectal exam. And the reason behind this is that these procedures might disturb the tumor if it's there, and that tumor can release biomarker or tumor marker and falsely elevate serum levels temporarily. And the last pre-analytical consideration is conditions other than cancer that can raise tumor marker concentrations. So a couple examples here are menstruating females. So in that demographic, CA125 might be falsely elevated during the time of menstruation. And another example is prostate-specific antigen. So if individuals with prostate have urinary tract infection, the levels of PSA might be falsely elevated in the absence of cancer. So these are some of the considerations that pre-analytical considerations that laboratorians should be aware of. As far as quality control is concerned, long-term assay stability is really important for tumor markers. And that's because post-treatment, oftentimes patient specimens are tested longitudinally for many years to detect the presence of recurrence before symptoms arise. And so if assays are not stable, then there might be a false elevation in the values. And so due to this consideration, lot-to-lot variation to a minimum is important. Another important consideration for tumor markers is standardizations. So some assays, for example, PSA, have been standardized, but others, such as for CA125, are not standardized. When I say standardization, I mean manufacturers using the same calibrator material to quantitate the values. And so as a result, when assays are not standardized, results from different methods are not interchangeable. And if the laboratory undergoes a platform switch, then rebaselining with the new assay compared to the old assay is required. And some of the other considerations are with respect to specimen handling, assay validation, and proficiency testing. And just like any other laboratory test, those need to be considered, and manufacturer recommendations should be followed. As far as interferences are concerned in tumor marker assays, there are three important factors that one should consider. So the first one is high dose hook effect. This is particularly important for some tumor markers whose levels can go very, very high, several hundred or several thousand fold high. For example, HCG. And when there is antigen excess, that can lead to high dose hook effect, as is shown on your right in a graph. So you can see that on the extreme right, there is an undiluted serum, neat serum specimen, which tested at a very low signal level and falsely underestimated the amount of tumor marker. But when you dilute that serum specimen and perform an 8,000-fold dilution, it actually is a very high value on that linearity curve that you can appreciate. So what this tells us is that if there is antigen excess, it can lead to high dose hook effect and falsely low tumor marker results. So some of the manufacturers are aware of it, and they incorporate wash steps to prevent high dose hook effect. Another thing that laboratorians can consider is doing dilutions or testing at two different dilutions. But again, cost versus benefit considerations need to be taken into account before doing that. As far as interferences are concerned, the second concern is specimen carryover. So let's say if there is a very high concentration of HCG in a previous specimen, and even a little bit gets carried over to the next specimen, which is actually negative, then that can cause false positive, which is not ideal. So as laboratorians, we need to be aware of that. And the last consideration is heterophilic antibodies. So these heterophilic antibodies or heterophile antibodies are human anti-animal antibodies, or they are sometimes human anti-mouse antibodies. And these antibodies can falsely elevate or falsely decrease the level of analyte. And so, as laboratorians, we need to be aware of that. And a couple things that, we can do to investigate a false elevation when clinicians reach out and the results don't match with the clinical scenario is to perform blocking treatment using commercially available reagents or to suggest using a different assay platform that uses a different set of antibodies. So those are some of the things we can do to mitigate interference due to heterophilic antibodies. As far as post-analytical considerations are concerned, there are a few things to note. So the first one is that trend is more important than a single result. On your right-hand side, you can see that there are dates that range from the year 1999 all the way up to 2003. And the first measurement at the top left is pre-treatment measurement, when a patient had a very high concentration of a certain tumor marker. And then they underwent treatment and their level were below the reference range or within the reference range. And for several years, those remained within the reference interval. And slowly the trend suggested that there was an increase in the tumor marker values. That's when a recurrence was realized and treatment too was initiated, which led to a temporary decline in the values. But then again, tumor marker concentrations kept on increasing. That suggests that there was a recurrence. And at that point, the patient was likely treated with a third treatment modality, which again temporarily reduced the levels of tumor marker. But shortly thereafter, they exponentially increased, suggesting another recurrence. So this trend, longitudinal trend, is more important when it comes to interpreting tumor marker results than a single result. Another important thing to note is assay and population-specific reference intervals. So these need to be, the reference intervals for tumor markers should be specific to the demographic that they are tested in. And interestingly, result for some tumor markers within the reference interval does not always mean that it's a normal result. So a good example is prostate-specific antigen. So individuals who undergo prostate removal, their clinicians expect PSA levels to be less than the population normal, right? And so if there is a persistent level of PSA in an individual who does not have a prostate, but the levels are within reference interval, may actually suggest residual disease. So this is an important consideration. And the last point here is what amount of change is considered clinically significant. So usually a change up or down of 25% is usually considered clinically significant. However, there are more studies that need to be done, each specific for individual tumor markers. So we talked about, consideration for laboratorians. Now let's talk about some limitations of tumor markers as well. So they are not always specific towards the intended cancer. An example here is that AFP is intended for hepatocellular carcinoma, can be elevated in other malignancies such as gastric, pancreatic, or lung cancers. Also, tumor markers can be elevated in non-malignant conditions. For example, acute cholangitis can lead to elevated CA19-9, or benign prostatic hyperplasia can cause elevated PSA levels. Another important factor is that tumor markers cannot really replace biopsy and surgical pathology and histology studies for establishing the primary diagnosis of cancer. They only serve as an aid along with other modalities. And the last point is that values within the reference range do not always exclude malignancy. So now let's talk a little bit about a more specific example of a tumor marker, which is CA125 in ovarian cancer management. So ovarian cancer is most frequently diagnosed in women who are 55 and 64 years of age, and routine screening of ovarian cancer is not really recommended because it does not reduce fatalities. But CA125 is a widely used serum marker for ovarian cancer. So how is it used? It is used in symptomatic patients who have symptoms such as bloating, abdominal pain, and even pelvic mass. So if these individuals are tested with CA125 along with pelvic ultrasound, it might speed up their referral to gynecologists or gynecologic oncologists. CA125 also has another utility. So it is incorporated as a variable in some algorithms. And an example here is risk of malignancy algorithms, ROMA, which are meant for preoperative assessment. So one other utility of CA125 in ovarian cancer context is that CA125 concentrations do reflect tumor burden, and it may serve as a prognostic indicator. And most commonly, it is used for post-therapy monitoring for disease recurrence prior to symptoms observed. So now let's wrap up with a few key takeaways. So the first one is tumor marker results alone are not diagnostic of specific cancers, but they may aid, and the key word is aid, in early evaluation of symptomatic patients. The third point is results trend is more important than a single elevated value. The fourth takeaway is a pre-treatment specimen provides very useful information in post-treatment monitoring. Results from different assay platforms are not interchangeable. And the last point is about interference. So high-dose hook effect and heterophile antibodies can cause assay interference in tumor marker assays. With that, I would like to thank you all for listening patiently and attending this conference. If you have any questions, please feel free to reach out at this email address. I would be happy to respond to them. Once again, thank you.